My name is Murray Fingerette. I'm an optometrist here in New York City. And I would like to thank the folks from Carl Zeiss Meditech for having this particular session. So there will be two parts to this. The first part is a particular talk, or in essence, or where we stand in regards to instrumentation and some of the changes that are occurring. And then the second piece I'll be talking about is there's some new software that recently has, that was just introduced for the Cirrus OCT, the 6.0, and I'll give you some examples and some cases of what I've seen recently. But the first part of the talk, and I welcome any questions, discussion, agree, disagree, because we're in the midst of an evolution of technology, and Carl Zeiss has really helped drive this. But we're in the midst of a technology evolution, in that we're seeing instruments available to us that, at least when some of us went to optometry school, they weren't even in our so-called, anything that we would envision or our future, and now they're here. So, the topic is, for glaucoma, do we still need to do visual fields with the availability of spectral domain OCT? So the first thing to talk about is, what's the glaucoma workup? And my remarks, for the most part, are going to be, talking about glaucoma, and what's the glaucoma workup? And it's history, visual acuity, measurement intraocular pressure, slit lamp, pachymetry, gonioscopy, and then we come down to the optic nerve fiber assessment, and I actually should put a slash right here and include macular assessment. And I'll come back and talk about that on the back end, because all of a sudden we're looking at evaluating the posterior pole, the macula, and it may also be a very good tool to see if their glaucoma damage is occurring, and possibly occurring early on. And then we have visual fields. And how we use those is going to vary, but for the most part, these are all part of the initial workup, and they're done initially, and then we do them periodically thereafter. And when we decide to do it is going to vary depending upon the diagnosis, as ocular hypertension compared to glaucoma, early glaucoma compared to a little more advanced. Controlled glaucomas, traditionally have had visual fields and dilated nerve assessment done yearly. Gonioscopy is typically done every couple of years, unless there's a change in status. In other words, if all of a sudden the pressure's sky high, you need to do gonioscopy again. The frequency of testing is going to vary depending also if the person is stable. If somebody's not stable, we'll do it more often. If the pressure is higher, or there's a greater amount of damage, we're going to do it more often. And then other times of the year, the patient is also going to be examined to assess IOP and perform tests. Well, over the past decade, it's really longer than a decade. We're really looking at 2 decades. The Stratus OCT has been around for, 13 years, 12 years. Looking at HRT, GDX came out in the early 90s. So we're really looking at about 2 decades. And over this time, there's been a shift in regards to the diagnostic instrumentation. And in particular, now we're looking at both availability, that many people have access. Even if you don't have one, most optometrists realize or know where they can have it done. And then just the quality of the OCT is improved. So the evolution to Fourier domain has allowed greater resolution, improved retest variability, and it allows us a much better understanding of if glaucoma is occurring, the damage, and if it is, where it is damage is occurring. And you get an idea of just how everything has gotten better and better and better. And you can see right here just how the resolution has gotten better and better and better on the spectral domain OCT. So Fourier domain OCT is superior to previous generations, no question about it. There's no evidence today that in regards to detection of progression, it's better, but that's a theoretical construct. I mean, I don't think anybody would disagree that when we have OCTs, over the next couple of years, so we have patients being followed for 3-4 years, and we start using the software like we just got with 6.0, we're going to have that available. And with that, and we're using it, we're going to start to see change. So, while progression right now hasn't been shown to be better with Spectral, and there are really very few papers that have looked at progression. I mean, that's just something that's going to come very quickly, and it's just one of timing. I mean, if you only have had an instrument for 2 years, 3 years, I mean, you're not going to be you don't have enough time, that window, but that window is going to be there, and so I don't think there'd be any question that spectral OCT is going to be superior to anything. It's in terms of progression also, not just detection, but we're just waiting for that. But the question I want to address is if OCT is so good, better resolution, you can see things you never saw before, you see nerve fiber layer loss, and then you see rim loss, you see macula changes. Can we forget about perimetry? And recent data suggest that that is what is occurring. This is the abstract that was published 1 year ago at the American Glaucoma Society, and this paper is now just been published in the journal Ophthalmology. And it's by Josh Stein. And what Josh did, Josh is a glaucoma specialist, and he's at the University of Michigan. And at the University of Michigan, through and they've done this work as part of a public health endeavor, what they've been able to do is get a very large managed care database. And as they've gotten the database, all the patient information is de-identified, but every time a doctor submits a claim for glaucoma, as part of that claim, then can see what tests were requested to be reimbursed. So in other words, what test did the doctor do on that particular exam? And they then will track those exams. And they have data, they have information starting in 2001. They looked again in 2005. They looked again in 2009. So 3 time points. So the purpose is to determine the extent by which new technology is affecting how clinicians are evaluating patients with open-angle glaucoma. An analysis of the claims data for all enrollees with glaucoma, and this is a large data set, so you're looking at almost 170,000 patients. So you're not talking about, a small number. In a national U.S. managed care network was performed to assess trends in visual field testing, fundus photography, and ocular imaging. They, in essence, did a relatively simple statistical formula, logistic regression, to identify difference in the odds of undergoing these procedures in 3 time points, 2001, 2005, 2009, and whether differences exist for patients under exclusive care by optometrist or ophthalmologist. Ooh, that's unusual to actually break that apart. In optometry, for the most part, has been spared most of these studies when people looked at practice patterns, and ophthalmology has usually been skewered. So they're actually looking at both groups. So without looking at this, what do you think? Let's just talk about fundus photography. How often do you think fundus photography was billed for people with glaucoma? Anybody want to venture a guess? How often do you think, and it may be being done more often than that, but this isn't just at one visit. So this looks at a 12-month period?
Every 6 months.
Every 6 months. No, I'm saying, like, do you think it was 100% of the glaucoma patients, 80%, 50%?
18, 20%?
And what is that?
Right, you're talking about
Yeah.
multiple visits over 1 year?
Over 1 year. Anytime during 1 year, they can have fundus photography done. So if you have 100 patients, of that 100, how many you think had photos taken? Okay, about 15%. Okay? What about visual fields for glaucomas?
Should be over 50.
Okay, you'll see, about 40, I think 46%. Imaging is far higher. So that's part of, so the odds of glaucoma patients undergoing visual field testing decreased 35% from 2001 to 2005, 13% further from 5 to 9, and overall 43% between 2001 and 2009. By comparison, the odds of undergoing imaging, which you're really talking about having an OCT performed, increased 102% from 2001 to 2005, 22% further from 2005 to 2009, and overall 146% between 2001 and 2009. So you got fields going way down and imaging going way up. For patients cared for exclusively by optometrists, the probability of undergoing visual field testing decreased from 66% in 2001. So for glaucoma patients cared for by optometrists, 2/3 of those patients had fields done in the year 2001. And in 2009, it was down to 44%. For ophthalmologists, the probability of field decreased 65%. So back in 2001, we were almost identical. And then they were 51% in 2009, so pretty close. The probability of undergoing imaging rose from 26% in 2001 to 47% in 2009 for patients, for optometrists, patients, and 30% to 46% for care by ophthalmologists. So in terms of imaging, we're identical. By 2008, glaucoma patients cared for by optometrists had a higher probability of undergoing imaging than visual field testing. And I mentioned fundus photography was relatively low, between 15 to 24%. And their in essence conclusion is by 2001, well, actually I'll go over here. Conclusions, because this is the actual paper, and you can go online to the journal Ophthalmology and get this right now. From 2001 to 2009, imaging increased dramatically, whereas visual field testing declined considerably because imaging has not been shown to be as effective at detecting glaucoma or disease progression compared to visual field testing. Increased reliance on imaging technology in lieu of field testing may be detrimental to patient care. So somewhat of a strong conclusion. And if you go to the paper, I mean, he has a host of statistics that break this out. And it breaks it out, you can look at the groups, and these are odds ratios, and they break it out by optometrist, ophthalmologist, both providers. You can look at fundus photography and where it came in. They even break it out by glaucoma suspect as well as glaucoma, and that's based on how they coded the claims data, and they provide these various these figures that show the probabilities, and they break it out by different groups, and how field testing is going down for both groups. So so that's the gist of where I'm starting from. That imaging has an OCT has led to a major evolution in how we take care of patients. But the question is that in any way affecting other parts of care? So the question is, are fields not being done, or being done less often, or is this strictly an artifact in data, and the data being contaminated and not reflective of actual practice because we're all aware of the limitations in regards to coding and insurance reimbursement, and that in most places, often you can't bill for 2 procedures if done on the same day, so you end up billing for the higher procedure. And up until last year, imaging was the higher reimbursed test. So it'll be interesting to see this data if we look at this, now, and we look at it, because now fields are far more have a much better reimbursement. So maybe this will skew. It will skew the other way. The other, though, issue is that when glaucoma specialists were broken out, 80% of glaucoma specialists, their glaucoma patients, had fields done in a 12-month period. So while general ophthalmology and optometry were not doing perimetry, cannot say this is strictly due to contaminated data, because glaucoma specialists, it's a lot higher. So there are other things going on. And maybe, do we still need to do visual fields? Perhaps clinicians are more astute or picking up on something before the so-called academics, whether it's myself or Dr. Stein, and maybe we're sending out a message that maybe we're wrong. Maybe, clinicians are actually seeing and in the trenches, so to speak, and maybe they feel that they can get away without doing a field as often. So there are a host of issues here. One of the issues, though, that need to bring up has to do with the medical legal issue, and that's a big one. And you cannot avoid that. And what do the medical legal things say? Well, hopefully nobody here will ever be put into a situation of having to deal with some type of litigation and a malpractice claim, because it's just plain bad. When having been an expert witness on several occasions, there are 3 things that, actually 4 things now, that the attorney gets. The first thing is they get the records of the exam. The second thing they get is some type of textbook on glaucoma, just in essence to provide background and data, because I wrote one of the glaucoma textbooks. I often hear that they use, that's one of the things that they use. And the third thing they get is what's called preferred practice patterns, or the guidelines. And both the American Academy of Ophthalmology has some, as well as the American Optometric Association has them. I'm familiar with them because I'm the author for the optometry's guidelines that came out not that long ago. Finally came out a couple of months ago. And if you're involved in following or diagnosing, or people are changing or missing the diagnosis, and you haven't done a field, I'm not sure what kind of defense you're going to have. It's going to be tough, because whether you read any of the textbooks, and you all know what they say, you read a textbook, you look at the ophthalmology guidelines, and ophthalmology and optometry in the court of law were considered the same. I mean, they're almost interchangeable. And the fact doesn't make a difference, because our guidelines, what are we going to write that would be different from them? Don't check pressure, they're very similar. So, you got, and they're all listed, but you're supposed to do fields for somebody with glaucoma on a yearly basis is the minimum, with the idea that you, as I said at the very beginning, you modify that interval based upon what a person, with their stage of disease, severity. And the Academy of Ophthalmology's guidelines are identical. So in terms of the medical legal viewpoint, fields are expected to be done periodically. What about the practical viewpoint? Do you still need visual fields to establish a diagnosis of glaucoma? Do you need them? No, you don't, exactly. No, I mean, it's not on, you can see nerve damage. You can make, you can establish a diagnosis that way. So, do you need fields to follow patients for glaucoma over time? So the first question is, do you need fields to establish a diagnosis of glaucoma? The answer is you really don't. So, but why should you know, what's the advantage of doing fields? Well, there are a couple of things. One is the stage of the disease. If there's no field, then then you know it's a mild case. If we, let me see if this is here. Here's the Academy of Ophthalmology's guidelines. In the Academy of Ophthalmology, they also define a breakout. They describe early, moderate, and severe glaucoma. Does anybody know what the ophthalmology's guidelines definition of early glaucoma is? Anybody have any idea?
No field.
What?
No field.
Exactly, no field loss. It's the same thing as the new coding guidelines for severity. There's no field loss. So when there's field loss, that's why you don't. That's why you need it. And if you don't see any, they call that mild. I don't quite believe in that, and we're not quite the same. But but fields are useful just to know the stage of disease, and they're also useful if there is loss to follow for time. The next question is, do you need visual fields to follow patients for glaucoma over time? Yeah, I mean, I couldn't imagine not having fields. Couldn't imagine it, to have to follow patients. I was lucky enough 20 years ago, it was probably close to 20 years ago, to be involved with a project, with Zeiss. That was the GPA, and I was, one of the sites. There were only a couple of sites that was involved. And I've always said that for all the things that Humphrey, and now Zeiss has done, and they've done a lot of really good things, but the jewel, in my estimation, is the glaucoma progression analysis for perimetry. It is a work of art, and they really did it. It's a phenomenal test, and they did it right. And while you can look at various criterion, it's a test that has withstood the test of time. And to not have that would be very difficult. So, now, do you even need retinal photography? Well, that's one where you can argue, you maybe you don't, but I would say, yeah, I do. So to confuse the further confuse the issue is that some insurers still consider OCT experimental, and it's absolutely amazing that at this day and age, with all the scientific papers that have been published, that you hear this come back and haunt you. But it still does. And it has to drive you crazier than it drives me. But I mean, but it's nuts. And is this a ploy to deny reimbursement, or is it something else? And it probably is. Now, to make it even crazier, so the FDA has to. There are two divisions there are many divisions for us. There are two principal divisions that we interact with. One relates to the pharmaceutical division, Wiley Chambers, and that's involved with getting medications approved. The other side is the device division that drives Carl Zeiss nuts. And this is the side that they need to, for software and things like that, get their instruments and things approved. For example, progression software needs to be approved, needs to be carefully vetted. And the amount of analysis that goes on is, I think if we would ask anybody who's involved in regulatory affairs, will tell you It's a pretty substantial process. In other words, to get software approved is not a simple task. And yet, so it's been approved by the FDA, the device side. But if a pharmaceutical company wants to have a drug that is going to spare the optic nerve, so in other words, it's not going to have any effect. The gold standard for pharmaceutical studies is to lower the IOP, usually with timolol, and now we're being replaced with timolol. But what happens if the medication doesn't lower the IOP, but it protects neuroprotection? It spares the nerve, enhances blood flow. How do you study that? The problem is you can't. You know why you can't? Because the pharma side doesn't believe that these devices work, literally. And that's what this was a particular that was done 2010. It's going to be done where another one's coming up this October. Measures of structural change, and these are the folks from the FDA involved. I actually did the piece with Gady Wolstein on the GDX to present the argument that there's sound data about why this instrument should be used to detect change and for pharmaceutical studies. Other speakers talked about OCT and HRT. And Wiley Chambers is in charge of the FDA's pharma side. Malvina Edelman is in charge of the FDA's device division. But that just goes you, so now if you have the FDA that won't buy in and say, well, these instruments aren't good enough for our studies, now it provides ammunition to why the insurers present that argument too, and it goes round and round. And it's just not right, but that's where we are. So, what's the purpose of visual fields? To recognize change, in part, to recognize loss, and then from there, what you would like to do is also use for progression. What's the purpose of OCT? Well, similar types of uses, both of them. Why are visual fields done infrequently by optometrists? Let's just go back to that, and ophthalmologists, as we discuss about managing the conditions. Well, I think there are multiple reasons. Are they uncomfortable with visual fields? I think that's in part one of the issues. Are they overly sensitive to patients when they say they don't want to do a field? I think that's another one. Are they too busy and want to reduce their exam time? Do they not understand how to analyze fields? That's hard to believe. I don't know. I mean, what are the other reasons? There are a host of reasons going on here about why, and I don't think they're one. Reasons for not doing fields as often and imaging is done is that imaging is clearly easy and quick to perform. Bingo. You got the answer. Requires little patient cooperation as compared to perimetry. It doesn't require subjective patient cooperation. It can be obtained without dilation. So there are a lot of reasons. You can see all the drawbacks. Fields take longer, require more cooperation, and they're subjective. And there are financial incentives. You purchase an OCT, which is more expensive. There's a reason to continue to use it and order the tests. And especially now with reimbursement changing and going down. Is Spectral, so there are multiple reasons why the data is what it is. And some of it is probably an artifact, but not all of it. Is Spectral OCT an improvement over older imaging technologies? No doubt about it. I mean, it's Spectral OCT. It has made a huge difference. Should imaging be part of the global glaucoma exam? It's getting there. Documentation is the standard, and we need to do that, but you can see all the uses of imaging. Today's imaging technology allows expert evaluation by non-experts. In other words, you start looking, you can start to see when people are comfortable in an analyzing printouts, you can an optometrist or ophthalmologist can be as skilled in detecting glaucoma as a glaucoma specialist.
Another nice thing about the new machines is they're just so much quicker as well. The old machines, it's just, the patient did have to stay still a lot longer. They took a lot longer to develop in terms of,
Yeah.
generating the imaging.
Yeah, no, you're right. I mean, nowadays, you can put a person down at a Cirrus, and from the time you put them in the instrument, plug their data in, to having the thing all done, and you can have it all done in 3-4 minutes. And that's a big deal. I mean, and the information you get is as I said, is really, it's quick, the ease of use, is there. And digital data with the OCTs is easily analyzed, and it's ideal for statistical analysis, and it's going to give us an objective rate of change. So there are a host of reasons why imaging is going to be more and more an important part of our glaucoma exam, and that's going to include reproducibility that's getting better and better and better. And we're throwing this data now into electronic medical records. And we're going to start with imaging. You're now looking at the enhanced depth analysis, looking at the laminar cribrosa, choroidal thickness, ganglion cell thickness. So imaging is going to allow earlier and more informed decisions than if we don't use it. And with improved software, we're getting better and better, and combining data, structure, and function is going to be a powerful tool. But is this an issue should be concerned about? In my mind, yes it is. Imaging has reset the bar in terms of what's possible, what we can do. Imaging has enhanced our care, unlike anything we had previously. But it should not take the place of perimetry right now. It's just, you really need both of them. I had, this morning I did a lecture on progression, and I spent 15 minutes showing multiple studies, and I was, and I surprised many people, because a lot of folks were under the idea that, for example, the nerve fiber layer is always the first place where you see damage as people get worse. People already have glaucoma. And I must have showed a dozen studies. And the dozen studies, so you had big numbers where you break out those Venn diagrams, and you see that every one of the studies was the same. Half the group changed on structure tests, half the group changed on field test function. And you couldn't predict which of the patients would change first, which way. But the idea of saying that this test is the best test for every patient just is ludicrous. It's just not, you need all the tests, and there's no way you can predict which test is going to be the payoff for your patient. I wish we could do that, but we can't. So that's why right now we need both. Will that change down the road? And I'm just going to change this particular one. It may. But right now, it has not. And with that, we're at a point where we cannot forget about, we need to include both particular tests.